Module 6, Justification, Referral Criteria. The learning outcomes from this module are shown here. We hope that at the end of this module you will have an understanding of what a referral criterion means, that you will understand the hierarchy of evidence that underpins clinical guideline development, and that you will have a knowledge of the available Sedentex CT referral criteria for cone beam CT. In terms of skills and abilities, we hope that you will know where to find the available sources of referral criteria for CBCT and for other dental X-ray examinations. We hope that you will be able to apply referral criteria to specific clinical situations. Our overall judgment and stance is that we should be striving for evidence-based use of cone beam CT. In the previous module, we showed that justification was the process of determining whether the use of X-rays to take a radiograph or to perform a cone beam CT scan is likely to provide benefits to the patient which outweigh the potential harm. Justification is a fundamental principle of radiation protection and is, of course, a requirement of the European Commission Council Directive. The risk-benefit assessment that is inherent in the justification process is, however, quite challenging in terms of dental radiology because the risks are low and the life benefits of dental radiology are also relatively low. What are referral criteria? Well, a referral criterion is a type of clinical guideline. Field and Law in 1992 defined clinical guidelines as systematically developed statements to assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. Referral criteria are not a rigid constraint on clinical practice. They are just a concept of good practice against which the needs of the individual patient can be considered. This highlights that referral criteria are about individual prescription of X-ray based imaging that is based upon an assessment of the individual's clinical signs, clinical symptoms, and overall status. In terms of European legislation, Council Directive 97/43 Euratom demands that Member States shall ensure that recommendations concerning referral criteria for medical exposure, including radiation doses, are available to the prescribers of medical exposure. While this statement clearly states medical exposure, remember that dental exposures are included under this heading. Why do we need referral criteria? Well, Radiation Protection 118, the European Referral Guidelines for Imaging, state that a useful investigation is one in which the result, either positive or negative, will alter management or add confidence to the clinician's diagnosis. This document also highlights the fact that a significant number of radiological investigations do not fulfill these aims and may unnecessarily add to patient irradiation. The reasons for this are as follows. One problem is that clinicians may repeat investigations which have already been done. The question to ask, therefore, is, has an investigation been done already? A second problem arises where an investigation is carried out where the results are unlikely to affect patient management. So the question to ask ourselves is, do I need it? Another problem is investigating patients too frequently. So the question to ask ourselves is, do I need it now? Doing the wrong investigation. We should be asking ourselves, is this the best investigation for a specific patient? Failing to provide appropriate clinical information and questions that the imaging investigation should answer. Have I explained the problem? Now, of course, in dentistry, the referrer for the medical X-ray examination and the practitioner are often the same person. but with cone beam CT there are sometimes instances where a dentist who does not have cone beam CT facilities may refer a patient to a colleague or to a hospital where those facilities exist. In those instances, correct communication is important to allow the practitioner in the referral centre to justify the examination. Finally, over-investigating. Here the question to ask ourselves is, are too many investigations being performed? Are all guidelines equally valuable? Well, by searching on the internet or by looking at textbooks, we can find guidelines on when to perform various treatments or investigations, including X-ray imaging. We need, however, to have an understanding of how valuable are different sets of guidelines. Some guidelines are merely expert opinion. This is defined as shown on the slide. It is where a group of individuals, or sometimes even just one person, comes to a conclusion about the appropriateness of an X-ray examination based on clinical opinion, often based on years of experience. The important thing to realize about this type of guideline is that it has a high risk of bias. Even where a panel of people is involved, there is a danger of one individual having a disproportionate influence over a decision. Some guidelines represent consensus opinion. Now, this often has some advantages in that a defined methodology may have been used to achieve consensus, but frequently these sorts of guidelines represent little more than expert opinion. The best guidelines are based on an evidence-based approach. This should be the strongest method of producing any clinical guideline. Things to look out for are a clear methodology, basis upon systematic review of the literature, critical appraisal, and data assessment, culminating in the production of a guideline statement with a clear evidence grade. As far as dental radiology is concerned, there are plenty of guideline documents, but these have an inconsistent national presence. So, for example, it is easy to identify guideline documents from the UK, some from Germany, some from France, but in other countries such guidelines do not exist. Furthermore, close examination of these guidelines indicates that there is an inconsistent level of evidence base. Some are based on an individual or a small group of individuals giving their expert opinion, whereas others are based on an evidence-based approach. An important resource is the European Guidelines from 2004 shown here. Note the web address at the bottom left-hand side of the screen. These guidelines included a chapter dealing with referral criteria and justification. These were based on a clear methodology of identifying evidence, critical appraisal, and guideline development. The problem with these guidelines is that, although they were produced in 2004, cone beam CT was never considered. In response to this, the Sedentex CT project was inaugurated in 2008. One of the aims of this project was the acquisition of the key information necessary for sound and scientifically based clinical use of dental cone beam CT. One of the objectives of the project was to use the information to develop evidence-based guidelines dealing with justification, optimization, and referral criteria for users of cone beam CT. At the start of the Sedentex CT project, however, it became clear that some early action was required to provide a foundation for the use of cone beam CT. Consequently, the Sedentex CT project, in collaboration with the European Academy of Dental and Maxillofacial Radiology, tried to establish some basic principles for the use of dental cone beam CT. A consensus process of EAD-MFR members was devised and, as a result of this collaboration, 20 such basic principles were devised. 7 of these, numbers 1 to 6 and number 8, are relevant to the justification process. Take time to look at these because they deal with fundamental aspects of justification. The first principle is that cone beam CT examinations must not be carried out unless a history and clinical examination have been performed. This is, of course, true for all radiology. The second basic principle is that cone beam CT examinations must be justified for each patient to demonstrate that the benefits outweigh the risks. What this is telling us is that there should not be a standard protocol for all patients, or for all patients in any particular subgroup. Each patient must be individually prescribed the examination. Number 3 states that cone beam CT examination should potentially add new information to aid the patient's management. Number 4, that cone beam CT should not be repeated routinely on a patient without a new risk-benefit assessment having been performed. This basic principle was included not least because there has been practice in dentistry of patients undergoing repeat examinations on a particular time frame, for example, bite wing radiography every 6 months or panoramic radiography every 2 to 3 years, neither of which are justifiable. Basic Principle 5 highlights the situation where a dentist may accept a referral from another dentist for a cone beam CT examination. In these instances, the referring dentist must supply sufficient clinical information to allow the cone beam CT practitioner to perform the justification process. Basic principle number 6 is an extremely important one. It says that cone beam CT should only be used when the question for which imaging is required cannot be answered adequately by lower dose conventional radiography. Finally, where it is likely that soft tissue evaluation will be required as part of the patient's radiological assessment, the appropriate imaging should be conventional medical CT or MR, not cone beam CT, which is, of course, primarily an imaging technique for hard tissues. The Sedentex CT project went on to conduct a thorough systematic review of the literature, culminating in the production of this document in May of 2011. These guidelines cover a wide range of clinical uses of cone beam CT. The remainder of this PowerPoint presentation will try to give an overview of the clinical uses of cone beam CT. These guidelines are given clear evidence grades, and you will see the details of how these grades are derived here. As we go through this PowerPoint, where we have a recommendation, you will see the evidence grade denoted next to the statement. In simple terms, if you were to see a grade A or a grade B, this suggests a higher level of evidence to support the statement. Where you see a good practice guideline, these are merely expert guidelines based on the clinical expertise of the guideline group. So let us move on to the clinical applications of cone beam CT. When we look at two images here, the one on the left is a conventional cephalometric radiograph, the one on the right is a cone beam CT image. One could say that there is no difficulty here. 3 dimensions are bound to be better than 2 dimensions. But just how true is that statement? It is important to understand that in terms of dental cone beam CT, we are often dealing with a trade-off of resolution against 3 dimensions. On the conventional radiograph on the left, a periapical of a lower left molar, you will see that the images are high resolution, but of course only 2-dimensional. On the right, we see cone beam CT images, and as we scroll through the volume, we can see that we are dealing with lower resolution, but we are gaining advantages in terms of 3 dimensions. In this particular example, if I choose an image from the middle of this section, you will see that we have identified a large carious or possibly resorption lesion associated with the distal root, which wasn't evident on the conventional radiograph. So clearly here 3 dimensions have been particularly important. But do compare the resolution of the 2 images. it is clear that the highest resolution is on the conventional radiograph. Let us have a think about what dentists actually do. Well, they look for dental caries. They treat and examine patients for periodontal disease. They treat pulpal disease, perform root canal treatments. They deal with patients who have traumatized their teeth and often their jaws. They perform orthodontic treatments or other aesthetic types of treatment. They fill gaps in the dentition by using dentures, bridges or implants, and of course occasionally they take teeth out. This is the scope for most dental practitioners who are not specialists, so we need to look at how cone beam CT could relate to these clinical tasks. First of all, let's consider caries detection. Here is a bite wing radiograph. We can all identify some carious lesions here, and there are indeed many more on this patient. How good are conventional radiographs at diagnosing dental decay? Well, Bader et al. In 2001 performed a systematic review of selected dental caries diagnostic and management methods, and they concluded that the mean sensitivity of bite wing radiography for caries detection was approximately 50%. In other words, that bite wing radiographs pick up about half of the carious lesions that may be present. The mean specificity was 87%, suggesting that sometimes we have false positive diagnoses of dental caries. So conventional radiography has its limitations in diagnosis of caries. What about cone beam CT? Well, there are inconsistent results between different cone beam CT systems. Clearly, some systems have different resolutions, different imaging characteristics, and so on. But the studies that have been carried out suggest that in unrestored dentitions, and that is an important point, in unrestored dentitions, in laboratory studies, cone beam CT may show depth of caries more effectively and the sensitivity may be better. So this raises the question, should we be performing cone beam CT examinations to diagnose dental caries? Well, of course, the radiation dose is higher with cone beam CT, even with small volume CT machines. The cost of the examination is higher economically, but one important practical point is the artifact problem. This is illustrated reasonably well here. These are images taken from a cone beam CT dataset, and the picture on the right, which is the axial section of the image on the left, demonstrates very well the sort of artifacts that appear on cone beam CT scans where there are existing metallic restorations. The artifacts illustrated here also produce apparent carious lesions, sometimes gross carious lesions, in the crowns of the teeth. The picture on the left is of a reconstruction from the data set on the right, and you will see in the crowns of the teeth many dark areas, representing not dental decay, but artifact. As a result of this, the Sedentex CT guidelines concluded that CBCT should not be used as a routine method of caries detection and diagnosis, and this has a B evidence grade, which is quite a high level. Let's move on to periodontal diagnosis, another very common task done by dentists. It is important to remember that the primary diagnostic method for periodontal conditions is a clinical one, done by using the eyes and by using the assistance of a probe around the necks of the teeth. There is no consensus and little evidence that really establishes the role of radiography in periodontal diagnosis. As a consequence, some practitioners will always use radiographs, other practitioners will rely purely on the use of a periodontal probe, and some will use a mixture of the two techniques. But what about cone beam CT? Well, one aspect of periodontal bone loss is that it is three-dimensional, and therefore it is an attractive proposition to use cone beam CT, because it will show the bone architecture in 3 dimensions. And certainly a number of publications have highlighted the fact that cone beam CT is superior to intraoral radiography for imaging complex defects, particular crater defects and furcation involvement. It is very attractive to use three-dimensional reconstructions of cone beam CT datasets to show periodontal bone levels around the teeth. Just one word of warning though, these three-dimensional images are produced by thresholding the dataset, segmenting it, so that it separates out the bone from the soft tissues. If that thresholding task is performed incorrectly, then it is easy to remove bone from around the teeth and therefore make bone loss from periodontal disease appear where it does not actually exist, and also to make existing bone loss look worse than it actually is. As far as periodontal use of cone beam CT is concerned, the Sedentex CT guidelines concluded with an evidence grade of C that cone beam CT should not be used as a routine method for imaging periodontal bone support. What the Sedentex CT guidelines also said was that cone beam CT may be useful in selected cases where we have infrabony defects and furcation lesions, where clinical and conventional radiographic examinations do not provide the information needed for management. Another task that dentists perform very regularly is endodontics, or root canal treatment. The research evidence is relatively weak here, but it appears that cone beam CT identifies more root canals than conventional radiography. All the research that has been done in this area has been on posterior teeth. This seems reasonable when the diagnostic task of imaging root canals is more demanding when we are looking at posterior teeth. The Sedentex CT guidelines concluded that limited volume, high resolution cone beam CT may be justifiable for selected cases where intraoral radiographs provided information on root canal anatomy that is equivocal or inadequate for planning treatment. This will most probably be in multi-rooted teeth. So its use in endodontics seems to be in those more challenging cases, such as perioendo lesions. In retreatment cases, such as this particular case here, this is a conventional radiograph of a patient who was referred for retreatment of the upper right first premolar. It is pretty obvious that there is a lot of extrusion of root canal filling material outside the root. But it was only on the cone beam CT scan where we were able to identify the perforation of the palatal surface of the buccal root, producing a furcation lesion. These kinds of complex retreatment cases may be more appropriate for cone beam CT. Also, resorption cases, where you have a challenging situation of either internal or external resorption, the cone beam CT may give us better information that will help determine the treatment plan for the patient if the intention is to maintain the tooth. Another task that dentists do regularly is periapical diagnosis, looking for evidence of inflammation in the tissues surrounding the end of the root. This is actually one of the most difficult areas to perform research on to establish diagnostic accuracy. Properly validated in vivo studies are effectively impossible because we need to section the jaw to determine the truth. Cadaver studies could be performed, but they are extremely challenging ethically in many countries. Animal studies are possible with appropriate ethical consideration, but even if performed extremely well, we have to ask ourselves whether they are strictly applicable to human beings. So very often the research evidence that exists is quite weak and relies on simple comparative studies, looking at the diagnostic yield of periapical lesions in populations that have received both conventional and cone beam CT examinations. An example of this is the paper by Lowe et al. In 2008, where it was shown that 34% of lesions were missed by periapical radiography. Now, while this is probably reasonably representative of the truth, we should remember that in this and in other similar studies that there is no reference standard, no truth with which the diagnostic yields of the two techniques were compared. It could be that cone beam CT diagnoses that were not shown on conventional radiographs were false positives. We just do not know. As a consequence, the Sedentex CT guidelines could only give good practice guidelines in this area, but concluded that cone beam CT should not be used routinely for the identification of periapical disease. But they did say that cone beam CT may be considered for periapical assessment in selected cases when conventional radiographs give a negative finding when there are contradictory positive clinical signs and symptoms. What about trauma to teeth and the dentoalveolar region? Here we have got some reasonably good evidence, and that is that cone beam CT offers increased accuracy in the detection of horizontal and vertical root fractures. However, it has been pointed out that high-resolution cone beam CT is important in diagnosis, so the ability of a cone beam CT piece of equipment to contribute to diagnosis is often dictated by its resolution capabilities. Another problem is the presence, once again, of artifact, particularly from posts and root fillings, which may complicate the diagnostic task. The example on the right shows the degree of artifact that arose from this post-retained crown, in a case where the cone beam CT was performed to assess whether there was any evidence of a root fracture. In this case, the results of the cone beam CT examination was equivocal. We could not make a diagnosis. So there are cases where it is not useful to use a cone beam CT examination in cases of suspected root fracture. Nonetheless, the Sedentex CT guidelines suggested that CBCT may be justifiable in the assessment of dentoalveolar trauma in selected cases where conventional radiographs provide inadequate information for treatment planning. What about trauma to the jaws? Well, it is important to establish the fact that in most cases, patients who undergo this severity of trauma will end up being seen in a hospital, not in a general dental practice. As such, a dentist should really consider hard whether it is worthwhile to perform a cone beam CT examination to look for jaw fractures if there is any clinical evidence of this. They might be better referring the patient to an oral surgeon in a hospital. Nonetheless, cone beam CT does have its uses in this area. Here is an interesting case of a person who was a sports player who was injured to the jaw during a match. The area around the lower right 8 was very sensitive to touch, and the patient was having great difficulty in eating and also some difficulty in opening their mouth. The panoramic radiographic examination did not demonstrate a jaw fracture, but it did give just a little suspicion that there was a widened ligament space along the posterior aspect of the third molar. This gut feeling from the clinicians and from the radiologist led to a cone beam CT being performed. The cone beam CT examination shows, as you can see, evidence of a fracture associated with the right third molar and angle region, which was not apparent on the conventional radiograph. A diagnostic task which is commonly performed by dentists is, of course, assessment of third molars, or wisdom teeth. This is used to establish the depth of the impaction, the number of roots, the divergence of the roots, but very importantly as well, the association of the tooth with the inferior alveolar canal because of the risk of damaging the nerve in the canal during the removal of the wisdom tooth. In terms of cone beam CT use, there are numerous case reports and non-systematic reviews on the use of cone beam CT as part of third molar assessment. And the focus has been very much on the lower third molar and the ID canal relationship. These studies have shown that cone beam CT reveals the number of roots of teeth more reliably than panoramic radiographs. If you look at the case on the right, the image at the top is part of a panoramic X-ray. The images at the bottom are coronal CT images of this tooth. Now, as we go through, you will see that we can see very clearly that there are 3 roots, reduced to 2 now until we get to the apex. Cone beam CT is giving us a lot of advantages in terms of characterizing the root morphology. But, as I said, one of the key tasks is looking for the relationship with the inferior dental or inferior alveolar canal. Here is a case on conventional panoramic radiography where the deviation of the canal and slight narrowing do raise the possibility of a close physical relationship between roots and canal. Here is the cone beam CT image of the same patient. What this is showing us very nicely is that the nerve and the neurovascular canal pass in a groove between the roots of this tooth. We can see it here on the axial view as well, and it has been shown in some, but not all, studies that cone beam CT is significantly better than panoramic imaging in predicting neurovascular bundle exposure during the extraction of impacted third molar teeth. Here is another example of a valuable cone beam CT examination. The image on the top is a panoramic radiograph. The image on the bottom is a reformatted panoramic from a cone beam CT dataset. Incidentally, we can all see the caries in this tooth. Let us look at the cone beam CT images now. These are coronal images, and we are starting off with a section through the apex of the lower right 8. What we can see here is the radiopaque round shape, which is the apical part of the root, and the radiolucent area on the right of the image, which is the lingual side of the root, which is the ID canal. It is flattened and very closely opposed to the root. As we move forward, we can see that the canal is beginning to split into 2. Now, as a little bit further forward, we can see it is distinctly 2 separate canals. Going further forward, we can see that the canal is moving away from the roots inferiorly, but superiorly we have a smaller canal branch going up towards the surface. So here it is clearly seen that cone beam CT has given us very good information about the number of roots, their morphology, and the relationship with the adjacent neurovascular structures. This led the Sedentech CT guidelines to say that where conventional radiographs suggest a close relationship between a mandibular third molar and the inferior dental canal, and when a decision to perform surgical removal has been made, cone beam CT is justified. I think it is important to emphasize here the phrase "when a decision to perform surgical removal has been made" is included in this guideline. Does it make any difference having this exquisite anatomical information? If, for example, no one is going to treat the third molar, then there is no indication for the cone beam CT scan. Similarly, if an oral surgeon routinely practices the process of coronectomy rather than full tooth removal for teeth that may have a close relationship to the inferior alveolar canal, then performing the cone beam CT examination would appear to give no benefit to the patient. So there are exceptions to the guideline. Other teeth are, of course, amenable to the use of cone beam CT, particularly in erupted maxillary canines. If you look at the axial image on the bottom left of the screen, you will see that the upper right canine has eroded the palatal surface of the lateral incisor root. And in cases where a decision has to be made about which tooth to extract, the canine or an incisor tooth, then cone beam CT can contribute very usefully to the management decisions for that particular patient. Here are some examples of impacted lower canines where the cone beam CT examination was performed for very similar reasons, partly to determine whether it was feasible to upright these canines, but also to assess whether any of the incisor teeth had resorbed. In terms of unerupted teeth, therefore, the Sedentech CT guidelines state that for the localized assessment of an impacted tooth, including consideration of resorption of an adjacent tooth, Where the current imaging method of choice is conventional dental radiography, cone beam CT may be used when the information cannot be adequately obtained by lower dose conventional radiography. And this was given an evidence grade of C. We've already covered quite a bit of ground, so let us just review what we have already covered. In terms of caries detection, cone beam CT is not justified. In terms of periodontal imaging, it may be justified in complex cases. In terms of endodontics, periapical pathosis detection, it is only generally justified in posterior teeth in cases where conventional imaging is non-diagnostic or gives equivocal results. For possible root fractures, it again may be justified when conventional imaging is non-diagnostic or gives equivocal results. In terms of impacted teeth for resorption assessment, it is indicated where conventional imaging is non-diagnostic or equivocal. And in the specific case of third molar assessment, it may be justified where conventional imaging suggests a close relationship with the neurovascular canal in the mandible. Let us move on now to think about a very important aspect of the use of cone beam CT, and that is orthodontic assessment. Why do I say this is important? Well, let us not forget that most orthodontic treatments are performed in children, the age group at which sensitivity to radiation is high. In addition, orthodontic patients often receive several X-ray examinations during the course of their treatment, so the overall burden of radiation can be particularly high. There are criteria for the use of radiographs in orthodontic treatment. This, for example, is a set of UK guidelines. But the use of cone beam CT can be particularly attractive to orthodontists. The possibility of having three-dimensional images when the purpose of orthodontics is to move teeth bodily through bone is particularly attractive. From cone beam CT datasets, orthodontists can reconstruct panoramic images by multiplanar reformatting to an appropriate thickness, as seen here. They can do the same thing to produce cephalometric images. Unfortunately, in a few cases it seems apparent that some dentists and orthodontists are performing the cone beam CT scan instead of conventional imaging purely for the purposes of producing a panoramic or cephalometric image. In other words, using a higher dose technique to produce essentially the same images. This has been highlighted by the UK Health Protection Agency in their recent report about the use of cone beam CT, where they stated that it is not appropriate to take a cone beam CT examination for the sole purpose of reconstructing a panoramic or cephalometric view if a lower dose radiographic technique would provide adequate diagnostic information. But in terms of using cone beam CT for routine orthodontic imaging, you can see the attraction from orthodontists of being able to look at the relationships between unerupted teeth, the roots of erupted teeth, in order to determine how best to perform their treatment. If an orthodontist chooses to move over to cone beam CT scanning for the everyday routine orthodontic imaging, an important aspect to consider is, does having this three-dimensional data set make any difference to the outcomes of treatment of the patient? There is a lack of evidence to support this. Indeed, the guideline document of the Sedentec CT project stated that much of the literature on using large volume cone beam CT for routine orthodontic diagnosis and treatment was anecdotal, case report and opinion based, with a lack of evidence of significant clinical impact. As a result, the Sedentec CT document could not give a guideline with a high grading level, but did state that large volume cone beam CT should not be used routinely for orthodontic diagnosis. The guideline did add that for complex cases of skeletal abnormality, particularly those requiring combined orthodontic surgical management, large volume cone beam CT may be justified in planning the definitive procedure, particularly where conventional medical CT was the current imaging method of choice. Let us move on to considering implantology. We should remember that one of the main drivers for the development of cone beam CT systems was the need for cross-sectional images as part of dental implant planning. Up to this point, many dentists were forced to refer patients to hospitals for medical CT scans, a practice which was both inconvenient and also could be associated with quite a high radiation dose. And there is a clear radiation dose advantage of cone beam CT over medical CT in most cases. There are also image quality advantages, as you can see here in this comparison between a cone beam and a conventional CT image of this same patient. This reflects the isotropic voxels and generally higher resolution associated with cone beam CT. In order to produce the required cross-sectional images, we perform multiplanar reformats of the dataset, as shown here, to produce cross-sectional images. Here is an example of some dental cone beam CT cross-sectional images produced from this patient on the left. In this case, a stent or imaging guide including artificial teeth have been used in order to localize the radiological situation to the clinical one. The Sedentech CT guideline document concluded that cone beam CT is indicated for cross-sectional imaging prior to implant placement as an alternative to existing cross-sectional techniques where the radiation dose is shown to be lower. The advantages of cone beam CT become greater where we are producing cross-section images of just a limited area of the jaws. Of course, with medical CT there is not the same option of reducing the scan volume down to a small size, and this is reflected in this guideline from the Sedentech CT document, emphasizing that the advantage of cone beam CT with adjustable fields of view compared with conventional CT becomes greater where the region of interest is a localized part of the jaws, as a similar sized field of view can be used. Imaging of the temporomandibular joint is also something that cone beam CT is capable of performing. It has been shown that cone beam CT has similar accuracy to conventional medical CT and indeed a greater accuracy than panoramic radiography or conventional tomography for the detection of osseous abnormality. However, we should always remind ourselves that most patients who present to dentists with temporomandibular joint symptoms are suffering from myofascial pain dysfunction or internal disc derangements. These are abnormalities of soft tissues and therefore may not have any radiological changes that would appear on cone beam CT or indeed on conventional radiography. As such, the Sedentech CT guidelines only stated that where the existing imaging modality for the examination of the TM joint was conventional CT, cone beam CT should be considered as an alternative where radiation dose is shown to be lower. However, I highlight again that most patients with temporomandibular joint symptoms do not require any radiological imaging. If they do require imaging, then magnetic resonance is the likeliest tool of choice. Let us now just briefly consider some other applications of the use of cone beam CT in the dental and maxillofacial area. Most of these are appropriate to hospital practice rather than ordinary dental practice, but they may be of interest nonetheless. The image data set you see here is of a patient who's fractured a root of an upper molar during extraction. Obviously here the cone beam CT gives us distinct advantages in localizing the position of this root prior to its removal by an oral surgeon. Cone beam CT is of use when we are looking at cystic lesions in the jaws because it gives us a good three-dimensional illustration of the position of the cyst, its relationship with adjacent structures, as here with the inferior dental canal, and also shows perforations of the cortical plates and expansion of those plates. Here we see an odontogenic tumour of the mandible in a child. Again, we are getting a good illustration of the relationships of the lesion with the adjacent teeth, which may be important if the lesion is going to be surgically treated, as here, and also the relationships of the lesion with the mental foramen and the inferior alveolar canal. Here we see a patient with fibrous dysplasia of the left maxilla, and this cone beam CT examination gives us very clear indications of the dimensions of the expanded alveolus and the texture of the bone. It is clear that cone beam CT could be used for a wide range of pathological and developmental conditions in the jaws. However, an important aspect to re-emphasize is that where it is likely that evaluation of soft tissues will be required as part of the patient's radiological assessment, the appropriate imaging should be conventional medical CT or MR rather than cone beam CT. Remember, this is one of the basic principles for the use of dental cone beam CT established with the European Academy of Dental and Maxillofacial Radiology. So, in summary, we have seen that cone beam CT has potential applications in many areas of dental imaging. We have seen that evidence-based referral criteria have been devised, but that these have mainly low levels of evidence grading. Metal-related artifacts may seriously limit the usefulness of cone beam CT in fine detail dental applications, particularly in situations like endodontics. Some diagnostic tasks require small volume, high resolution cone beam CT, so it is important to remember that referral criteria may not be the same for all cone beam CT systems. But probably the most important message to take home is this one, that cone beam CT should only be used when the question for which imaging is required cannot be answered adequately by lower dose conventional radiography. We acknowledge that the research leading to these results has received funding from the European Atomic Energy Community's 7th Framework Programme.